Hi, good morning, everyone. And for all of those who don't know me, my name is Ida. I'm one of the staff nurses under line 3. And today is going to be about a presentation regarding ACS or acute coronary syndrome. So this presentation was prepared with the guidance of Sister Pranita. She gave me a lot of feedback and support. So for that, I'm very thankful. For this presentation, we've got 20 minutes, so let's crack on. So what is ACS? Acute coronary syndrome actually includes a spectrum of 3 different disorders. First is STEMI, or ST segment elevation, myocardial infarction. Second is NSTEMI, non-ST segment elevation, myocardial infarction, or also known as non-Q-wave MI. And third is that we have unstable angina. Outside of these 3, there's actually chest pain that is stable. So stable angina pectoris is defined as chest pain relieved by rest and GTN after 5 minutes. So what is the pathophysiology of stable angina pectoris? How does it cause chest pain or angina? So for that, it starts with increased oxygen demand, like when there's increased preload or increased ventricular volume. It can also start after increased afterload or high blood pressure, and these things cause increased oxygen demand. When this happens, the narrowing of arteries occur, which leads to myocardial death and ischemia. And then when the ischemia happens, chest pain happens, and that's where what we call stable angina, when the chest pain is relieved by rest and GTN after or within 5 minutes. Going back to the main topic, which is ACS, there are actually 3 types of ACS as mentioned, and this is actually a very good illustration to show the differences amongst the 3. So the first picture here on the left side is unstable angina. As you can see, there is partial rupture of an artery, and it does not cause permanent damage to the heart. On the other end of the spectrum, we've got STEMI. This is what we call the classic heart attack. There is extensive heart damage. As you can see, there's extensive blockage as well. And in the middle of unstable angina and STEMI is actually NSTEMI. So as we can see on the right picture, NSTEMI is an intermediate form of ACS. There is ischemia and there is some damage, but it causes less extensive damage to the heart than STEMI, but more damage to the heart than unstable angina. So what is unstable angina? It is defined as ischemia without acute injury, acute cardiomyocyte injury or necrosis. What the length of duration? If stable angina occurs and is relieved within 5 minutes, unstable angina is prolonged. It takes 20 minutes of angina at rest. It can also be a new onset of severe angina. In terms of frequency, chest pain could be more frequent, could be lower, or there could be lower threshold, meaning just a little bit of exercise and the patient already has chest pain. Also, unstable angina can also occur if the patient has had a recent episode of MI, which means that if we admit the patient or treat a patient with MI, we have to always be cautious about what if this patient is having another episode of unstable angina, which means that there's low threshold for us to do the tests that we need to assess the patient. Next, we've got MI, so myocardial infarction. This is where there is injury and ischemia and injury. With myocardial infarction, myocardial necrosis develops because of the imbalance of the oxygen supply and demand. How does MI develop? So what's the pathophysiology? Normally we see it in the coronary arteries where plaque ruptures and causes formation of thrombosis. Because of the blockage of the thrombosis, there is an acute reduction of blood supply to the myocardium, causing imbalance in supply and demand of oxygen. When this imbalance is prolonged, it can cause myocardial tissue necrosis. STEMI is a form of MI where there is ST segment elevation on the ECG. With STEMI, myocardial death occurs because of the prolonged mismatch between demand and perfusion, as mentioned earlier. As we can see on the illustration, the picture above is the normal ECG. So we got the P, QRS, ST segment, and the T wave. This is the normal electrophysiology. Now with STEMI, we could see this humpback waveform where the ST segment is above the isoelectric line. So this is something that we could see on the leads of the ECG. There are actually two types of acute MI. There's the transmural MI, where there's complete occlusion of blood supply, and subendocardial MI, where there are smaller areas of involvement, or the involvement of the tissue damage is multifocal. Now we've got NSTEMI, or non-ST segment elevation MI. With this, there is ischemia, there is necrosis, but the ECG may be normal or show non-specific changes. So that's the main difference. With non-NSTEMI, we might not be able to see that humpback wave, the classic electrophysiological waveform, but there could be some non-specific changes or no ECG change at all. So now the question is, how does all of this information, how can we apply it to our nursing care? The best thing that I thought about approaching it is how we incorporate it in our nursing process of API, assessment, planning, intervention, and evaluation. So under assessment, we've got A, B, C, D, E, skin, and we've highlighted pain because in conscious adults, chest pain is the most frequent presenting complaint for ACS. So let's start with airway. With airway, we always look for signs of airway compromise because a cardiac arrest may be preceded by pulmonary aspiration. So signs of airway compromise that could be specific to a cardiac arrest would be coughing and wheezing. To an ACS, is coughing and wheezing. And other signs of airway compromise that might be a result of pulmonary aspiration include excessive secretion, cyanosis, seesaw breathing, use of accessory muscles, diminished breath sounds, and also added breath sounds. With the breathing, we always look first with our vital signs. So under breathing, the two main vital signs are SAT and RR. So with SpO2, any change outside of that patient's normal or any change with If the oxygen level does not fall within the target range, like 94 to 98%, and for normal patients, and between 88 to 92% for patients with COPD retaining CO2, then we would always think about potential ischemia. In terms of the respiratory rate, our initial sign would be shortness of breath. Is the patient having tachypnea? And then when the ischemia is prolonged, the patient may have periods of apnea, indicating that it's worsening. And of course, the very, very late sign where there is cessation of breathing would actually prompt us to call for a cardiac arrest. Also, upon auscultation, we specific for ACS or MI, we might see or look for coarse crackles, because if these are present, including crepitations, it might be that the patient is having pulmonary edema due to the impairment in cardiac function. Next, we've got the cardiovascular. Our vital signs under this include BP, pulse rate, and temperature. For our BP, initially, patient's initial response would be hypertension. But as we mentioned earlier, hypertension could actually increase the afterload and therefore further increase oxygen demand. When that's prolonged, the late sign, which is hypotension, could lead to cardiogenic shock. In terms of the pulse rate, initially the patient could have tachycardia, and then once again, as peripheral perfusion diminishes, bradycardia can also result, which is a late sign and can lead to cardiogenic shock. And of course, the last thing that we don't want to happen is pulselessness or lack of cardiac sounds. So when the heart stops beating again, this would be a cardiac arrest. Temperature-wise, initially the patient might not be febrile, but if they have already a coexisting infection, this is something we need to consider. Patients also with ACS, they might develop a fever as part of our catecholamine response. Our catecholamine response is actually our fight or flight response, and catecholamines are hormones that are released in response to stress, such as emotional stress or physiologic stress. Cardiovascularly, we have to also consider the ECG if we're noticing arrhythmias starting to come up. Upon auscultation, specific to ACS, we might hear a pansystolic murmur, and we could also potentially see raised jugular vein pressure as a result of increased BP and increased demand for oxygen. Now, with disability and neurovascular, our main vital sign for this, our fifth vital sign, would be pain. Chest pain, this is normally described as a feeling of pressure, heaviness, and tightness or squeezing. Okay? This is cardiac sounding chest pain. Now, chest pain is the most common presenting complaint for both men and women, but women are more likely to have other symptoms such as shortness of breath, nausea and vomiting, back pain, and jaw pain. There could also be pain elsewhere in the body. It can feel like there's a spread, starts from the chest and radiates to the arms. Usually the left arm is affected or has symptoms, but it can affect both arms and other areas as well. With the ACVPU, we have to see if there's declining level of consciousness. If it's a true ACS, that's a sign that there's increasing demand for oxygen that the body is no longer able to provide, causing ischemia even to parts of the brain. So when the patient is unconscious or unresponsive, it's a late sign and also denotes cardiac arrest. For the pupils, we have to check normally as the patient gets sicker, we might notice that the patient's eyes might constrict if the cardiac arrest is caused by anything else, like medication, pupils might dilate. It depends. So we have to assess and correlate the information that we get. Neurovascularly, patients with ACS could feel lightheaded, they feel dizzy, they could be feeling nauseated and vomiting. There's also this potential feeling of impending doom and gloom. There's a overwhelming feeling of anxiety that's very similar to a panic attack. And patients can also present to A&E or we admit them and their presenting complaint is actually syncope. They already had a collapse. Exposure and elimination. The clinical picture of someone having a classic MI, you would see them clutching their chest, they're very sweaty and they're very pale. And then we could also look for clues around the patient. Does the patient's belongings have cigarettes? Do their clothes reek of cigarette smell? These things actually can represent a cardiovascular risk. There's also we should also be on the lookout for clinical signs like active bleeding, like if the patient has a brain bleed or active bleeding elsewhere. Bleeding is actually a precipitating factor also to MI apart from aspiration pneumonia. Elimination wise, we should check the urine output. Oliguria or anuria can represent that the kidneys are already not well perfused by the not well perfused because of the blockage that's already happening in the coronary arteries. So this slide, we've got a slide for family communication and visiting because it's one of the things that we are being encouraged to document about. The main thing about this slide is emphasis on transcultural nursing, specifically with regards to language barriers. Because based on my personal experience for conscious patients who do not speak a word of English at all, it can be helpful to work in partnership with their relatives so that we can call them to ask what the patient feels like during the day, because some patients they want to say they're having chest pain, but they don't know how to say it in English. So we can call the relative and say, can you please let us know what the patient is telling us so that we could understand them? And in cases when this is not appropriate or not a possibility, we could employ the use of an interpreter. Of course, we have to speak to the nurse in charge about it. And this slide, we just want to emphasize if the patient is having a cardiac arrest, unconscious, unresponsive, we call for help and to please follow the adult resuscitation guidelines and local policy. After assessment, we plan. Mostly we anticipate and perform investigations. A chest x-ray can be ordered for suspected pulmonary edema, but it should not delay ACS management at all. Also, we can do serial ECGs so that we could see if is there ST segment elevation? Are there other signs of ischemia in the ECG? And then if we have to make sure that the patient has IV access for us to be able to get ABG or VBG, blood tests including FBCs, USNEs, LFTs, lipid profile, clotting, and glucose. And then another thing that we have to include in our blood test is the troponin T, a baseline troponin T, and then we retake an hour later. So these three things that are in bold and underlined are actually part of our trust policy for ACS. Disability, we have to anticipate for possible CT head if there is suspected intracranial pathology. Depending on how sick the patient is, we might need to involve our transfer team. And of course, indwelling catheter for patients who are not already on indwelling catheter, we have to put one in for fluid balance monitoring if they're really sick. And then this is just a slide to show ECG changes we might expect. For STEMI, it's of course ST segment elevation and new left bundle branch block. So just the picture on the right shows actually a left bundle branch block. In lead 1 and V6, it looks like this, like there's an RSR phenomenon instead of the usual QRST. Then it looks like this on the V1. V1 is reversed, so it looks the opposite because V1 is on the opposite side of the chest, and the rest of the leads, V2, 3, 4, 5, 6 are on the left. And STEMI, we might see T-wave inversion and or ST segment depression. And in unstable angina, there's normally no specific ECG abnormalities. They could say non-specific ECG changes with chest pain. That's unstable angina. Intervention. Airway-wise, if the patient has had aspiration, we might expect or anticipate that airway adjuncts will be used, and maneuvers like the head tilt, chin lift, jaw thrust could be used during an emergency. Deliver oxygen if hypoxic. So if the patient's SATS is less than 90%, or if the patient is in obvious respiratory distress, we start oxygen. We anticipate the need for CPAP, NIV, or intubation. So CPAP will likely be started for patient who had aspiration pneumonia first. But then again, since we're in critical care with patients have varying degrees of needs, we might also need NIV or intubation. So circulation fluid resuscitation, as per policy, we have to exercise caution in patients with heart failure because we don't want to overload the heart. We might need to start BP support medications like inotropes and also manage electrolytes as required. And our main classic treatment for ACS would be MONA. We've got morphine, nitroglycerin with aspirin and clopidogrel. Nitroglycerin, we should exercise caution if we notice the patient's blood pressure dropping, as nitroglycerin also causes vasodilation and may exacerbate hypotension. If advised, if the patient is not allergic, we start aspirin 300 milligrams. This is stopped with clopidogrel 300 milligrams. So we have to really give it as soon as possible. When you see that, it's one of our priorities to give. Fundoparinox 2.5 milligrams subcutaneous is given if the patient was not previously on any anticoagulation. But we do not give fundoparinox if the creatinine clearance is less than 20 ml per minute. For patients who are already taking warfarin or low molecular weight heparin or DOACs, direct oral anticoagulants, an enoxaparin is given instead. The ACS dose would be 1 milligram per kilogram. If the patient has continuous ongoing chest pain, we would also potentially have to start an IV GPN infusion. The main thing about this is that we monitor the blood pressure and to stop if the BP is less than 90 mmHg, or even before this if you feel like the patient's really sensitive with their blood pressure drops. If the patient has pulmonary edema, we might expect furosemide to be given as a diuretic. And again, for diuretics, we use cautiously if the patient is hypotensive. Now, in other forms of intervention, if there is clinical evidence of STEMI that require urgent PCI, this discussion will be made by the doctors with the interventional cardiologist ASAP. PCI is percutaneous coronary intervention. We want them there as soon as possible. So if the patient loses consciousness, there's no signs of life on assessment, we call for help and follow the resuscitation policy. If needed, in some cases, we have to do CPR as well. How do we know if the patient is getting worse or getting better, or if we need to do more investigations, more interventions? So we have to continuously reassess the patient after any intervention, meaning regular blood gases, regular assessment if our airway management of our air is working, is the patient getting better, getting worse, and also we have to check the results of the test, especially the troponin test, because it will confirm the diagnosis of ACS. So troponin is a cardiac biomarker. It's actually a protein complex. It's involved in muscular contraction. And there's 3 types. There's troponin C, troponin I, and troponin T. For reduced level of consciousness, it's not only ischemia that can cause reduced level consciousness. So we have to review the drug chart. If the patient is on any opioids, sedatives, anxiolytics, is the patient having too much insulin or oral hypoglycemic medications? So these things can cause reduced level of consciousness. And we also have to continuously reassess the fluid balance of the patient. Oliguria is normally half, if the patient's urinating less than half of their body weight. So that's 0.5 ml per kilogram per hour in an adult. And so we've just got these useful links. This was taken from the ESC guidelines and is also available in our Trust ACS policy. Basically, not all chest pain is cardiac. And these are the differentials. This table shows the differentials. There's cardiac, pulmonary, vascular, GI, orthopedic, and other causes for acute chest pain. So these are the differential diagnosis. We'd encourage you to have a look at it when you have time. And this table shows that there are other conditions apart from acute MI that can cause cardiac troponin rise or elevation. So we've got things like heart failure, shock, sepsis, burns, myocarditis, hypertensive emergencies. So this is a good if the troponin is negative, these are the things that we could explore. So that's the end of our presentation. Thank you all so much for listening. And if you have any questions, please let us know. We could also send these slides over if you'd like them. Thank you very much and have a nice day.